All right, team. Welcome to Neoplasia, aka When Cells Decide the Rules Are Optional. This chapter is all about new growth, but not the cute kind like houseplants. We're talking about growth that's heritable, autonomous, and persistent, meaning the cells don't just stop because the body politely asks. From a histotechnology lens, this unit matters because neoplasia shows up as pattern changes. Architecture gets messy, nuclei start acting dramatic, and tissues lose their normal neighborhood vibe. Our job is to help produce slides that let the pathologist answer, is this controlled growth or chaos with the blood supply? So let's start with what you're expected to be able to do by the end of this lecture. These objectives are basically your roadmap for how we'll think through neoplasia, not just memorizing terms, but connecting the biology to what we actually see on tissue sections. A few themes to keep in mind as we go. Where did it start? So the cell or tissue of origin matters a lot. How does it behave? Is it slow and polite, or is it fast and invasive? How does it spread? Is there local invasion or metastasis, which are two very different problems? Why does it happen? Are there gene changes? Are there carcinogens? Were there viruses, radiation? The usual villains. And in true histotech fashion, we're going to keep asking, what would this look like on H&E? What clues show up in tissue architecture, cell shape, and nuclear detail? Okay, before we start comparing benign and malignant, we need clean definitions. Let's break these down in a way that actually sticks. So neoplasia means new growth of cells. But the key phrase here is heritable, relatively autonomous. So these cells aren't just reacting to injury like hyperplasia might. They've picked up genetic changes that let them keep going. Tumor. A tumor is simply a mass or swelling. Important point though, tumor does not automatically mean cancer. It's a shape structure term, not a behavior term. Benign neoplasm. Benign tumors are localized and discrete. They stay in their own lane. They may grow, but they generally remain confined to their site of origin. Malignant neoplasm. These malignant tumors have the potential to invade and spread beyond where they started. This is where histology starts giving off warning signs. Irregular borders, infiltration, abnormal nuclei, and architectural disruption. When you're cutting and staining, your tissue handling matters because the diagnosis often depends on subtle clues like the border, the pattern of invasion, or nuclear detail. And those can be lost fast with thick sections or chatter, folds, or even incomplete fixation. Now let's compare benign versus malignant the way the microscope sees it. This table is basically the personality comparison between benign and malignant tumors. So we have growth rate. Benign is slow, whereas malignant is rapid, often, but not always. Some malignancies are sneaky slow. Borders, benign would be encapsulated or well circumscribed, and malignant is usually irregular and infiltrative. This matters because infiltration can look like tumor cells threading into normal tissue, ignoring boundaries like they're on a bad road trip. Metastasis, for benign, we wouldn't see any, so none. And for malignant, there would be present, but oftentimes later. Metastasis is the hallmark behavior that changes everything clinically. Mitotic figures are very rare on benign neoplasia and frequent with malignant. And sometimes abnormal looking mitoses, the cell division equivalent of this is not going well. Differentiation, benigns are going to be well differentiated, still resembles tissue of origin. And malignant are going to be poorly differentiated. They're going to be less recognizable, more primitive looking. Nuclear size and nucleoli. For malignant cells often show enlarged nuclei and prominent nucleoli. This is why good nuclear preservation is everything. So, overprocessing or poor fixation or harsh antigen retrieval on some tissues can distort these nuclear features. And those features are often what makes the diagnosis. Okay, the next slide gets super important, invasion versus metastasis. The two big behaviors, invasion and metastasis, they're related, but not the same. Invasion is direct extension into surrounding tissue. In plain language, the tumor doesn't stay neatly contained. It pushes through normal boundaries. Histologically, invasion often shows irregular tumor nests or cords infiltrating stroma, disruption of normal architecture, desmoplasia, which is just a fibrostromal response in many carcinogens, or I'm sorry, carcinomas. And sometimes tumor cells crossing what should have been a stop sign, like a basement membrane. Metastasis is when tumor cells leave home, travel via lymphatics, the blood, or seeding across cavities, depending on the tumor type, and successfully grow somewhere else. That last part is key. Lots of cells can enter circulation, but metastasis requires survival, escape, and colonization. It's not just travel, it's relocation and thriving. The slide highlights common metastatic destinations: the lymph nodes, the lungs, the liver, bone. In practice, metastasis can show up as, why is there a gland-looking tumor in bone? Or why does this lymph node have epithelial cells in it? That's when tissue pattern recognition really earns its paycheck. Now that we've nailed the core definitions, next we'll start building the story of how cancer develops and why they behave the way they do. This slide is your first real introduction to how pathologists name things. And yes, sometimes it feels like learning a foreign language that was invented by someone who hated consistency. Benign neoplasms generally end in oma, and they're named based on the cell or tissue of origin. From a histology standpoint, this matters because benign tumors usually look like what they came from, just more of it and in the wrong place. So when you see lipoma, think mature adipocytes, well organized, no chaos. Leiomyoma is smooth muscle bundles, whorled pattern, cigar-shaped nuclei. Chondroma, cartilage matrix that looks like cartilage should look. Benign tumors are basically the tissue equivalent of an overachiever who didn't know when to stop. So excessive growth, but still following the rules. From a lab perspective, these lesions are often well circumscribed. Cells are uniform or absent. Architecture is preserved. This is where you start training your eye to say, okay, this tissue is behaving politely. Slide introduces carcinomas, and if cancer had a popularity contest, carcinomas would unfortunately win. Carcinomas arise from epithelial tissue, which explains why they are so common, because epithelium is everywhere and is constantly dividing. Histologically, carcinomas lose their normal architecture, they show pleomorphism, they have increased nuclear to cytoplasmic ratios, and display abnormal mitotic figures. A key naming rule, squamous epithelium is going to be squamous cell carcinoma. Glandular epithelium is adenocarcinoma. So when you hear adenocarcinoma, your brain should immediately think glands, ducts, secretory structures that have completely lost their organization. From a histotechnology standpoint, carcinomas often require careful sectioning to demonstrate invasion. Benefit from special stains or IHC to confirm epithelial origin. They show variable differentiation from almost normal looking to completely unrecognizable. And this is where things stop playing nice. Sarcomas are the troublemakers of the connective tissue world. Rarer than carcinomas, but often more aggressive. Sarcomas arise from mesenchymal tissues, so bone, cartilage, muscle, and fibrous tissue. Histologically, carcinomas tend to be highly cellular, show spindle-shaped or bizarre cells, have minimal organization, and invade aggressively. And then we have the special category tumors. So lymphomas and leukemias. They are of a hematopoietic origin. Glial cells arise from gliomas arise from glial cells. Melanoma comes from melanocytes. And yes, one of the famous omas that is definitely malignant. Fun but mildly evil trivia is melanoma keeps the oma ending because medicine likes to keep students home. Um, for histology, sarcomas often require orientation clues. So architecture is minimal, so cellular detail becomes critical. So tissue handling matters. These tumors can be fragile and necrotic. Slide is here to answer the question students always ask. Why do we see this cancer all the time and almost never that one? Skin cancers, especially basal cell carcinomas and squamous cell carcinomas, dominate because skin is exposed to UV radiation. The cells divide frequently, and DNA damage accumulates over time. The pie chart reinforces an important concept. Cancer frequency is not evenly distributed across tissues. From a lab perspective, common cancers equals common specimen types. That means repetition, which helps pattern recognition. It also means these are the tissues where good histology really matters. Screening comes into play here too. So pap smears, colonoscopies, mammograms. Screening doesn't eliminate cancer, it catches it before it becomes a histologic nightmare. This slide is one of the most important conceptually because it shows that frequency does not equal lethality. Look at lung cancer. Not the most common, but one of the lowest survival rates. Why? Late detection, aggressive behavior, and early metastasis. Contrast that with prostate cancer, which is common, has a very high survival rate, and is often slow growing and detected early. From a histotechnology perspective, this slide reinforces that early detection equals better outcomes. Quality sections will equal accurate staging. Accurate diagnosis influences everything downstream. What you do at the bench directly affects how quickly and accurately disease is identified, even when patients never know your name. All right, here's where cancer stops being just a lump problem and becomes a DNA problem. Cancer is fundamentally a disease of genes, meaning something has gone wrong in the chromosome structure, the DNA sequence, or even both. And before anyone panics, one single mutation does not cause cancer. If that were true, none of us would still be alive. Your cells accumulate mutations every single day. Most are harmless, many are repaired, and some cells are politely escorted into apoptosis like, thank you for your service, but goodbye. Cancer requires multiple genetic hits, plus environmental or contextual factors. Think of this like the zebra-horse hybrid. One odd trait doesn't make a new species. It makes multiple genetic changes, or it takes multiple genetic changes, and even then, the environment has to allow it to survive. When those changes finally matter, we start seeing it under the microscope as abnormal nuclear size, irregular chromatin, loss of normal tissue architecture. Your body replaces approximately 330 billion cells per day. Statistically, cancer should be more common. The fact that it isn't is actually a win for DNA repair. This slide is important because it answers the question patients always seem to ask. Did I pass this on? Or did I inherit this? Somatic mutations, these occur in non-germline tissues. So they are not inherited. They are limited to the tumor itself. And then we have germline mutations. These are present in the egg or sperm. They are passed to offspring and they affect every cell in the body. Somatic mutations are like spilling coffee on one page of a book, and germline mutations are like printing the typo into every single copy. This matters because germline mutations often lead to earlier onset. Tumors may appear in multiple sites, and background tissue may already look off compared to truly normal tissue. Notice how in germline mutations, every cell is affected, not just the tumor. This is where we revisit the definition of neoplasia, and this part matters. Neoplasia equals hereditably altered, relatively autonomous, new growth of cells. Heritable here does not mean inherited from parents. It means passed from one cell generation to the next. Genetic alteration occurs, the damage is detected, repair should happen. If repair fails, apoptosis should occur. If neither happens, the cell divides anyway. And once that cell divides, well, congratulations. You now have a clone. This is why tumors often look monotonous, repetitive, or clonal, because they literally are. It's like photocopying a typo 10,000 times and then wondering why the document looks wrong. This table is basically a checklist of how cells learn to cheat. Walk through the highlights rather than read every row. So increased mitosis is going to give us more cells faster, right? A decrease in apoptosis, we're going to have damaged cells that don't die. Decreased response to growth inhibitors is kind of like no breaks. And then an increased extracellular matrix digestion is going to show invasion. Immune evasion is going to be a sign of survival, right? Metabolic flexibility means we're going to have growth anywhere. These changes explain what we see on slides. So we're often going to see crowded nuclei, a high mitotic index, loss of normal boundaries, tissue invasion instead of respect for layers. Some worthless knowledge here is that cancer cells often rely on glycolysis, even when oxygen is present. So we call that the Warburg effect. Basically, cancer cells prefer fast junk food over efficient metabolism. Transformation is the point of no return. So transformation equals genetic defect that is not repaired. The cells divide anyway, and then mutation becomes fixed in the daughter cells. At this point, a normal cell becomes one with the potential to generate a neoplastic clone. An important characteristic or clarification here is that mutation does not equal cancer, and transformation does not mean visible tumor. But transformation is the gateway. This explains why we sometimes see dysplasia before invasion, architectural disruption before metastasis, and subtle nuclear changes before a mass even exists. Transformation is like disabling the smoke detector and the fire extinguisher at the same time. Okay, this slide is where cancer genetics really starts to feel less abstract. Think of oncogenes and tumor suppressor genes as opposite ends of the same highway. Oncogenes is the gas pedal, and the tumor suppressor genes are the brakes. So oncogenes. Proto-oncogenes are normal genes that every healthy cell needs. They help cells. They help cells respond to growth signals, enter the cell cycle, and divide when appropriate. The problem happens when a proto-oncogene mutates and becomes an oncogene. That mutation essentially locks the gas pedal down. Only one allele needs to be mutated. This is usually not inherited. The cell now behaves like it's constantly being told, grow, divide again. These changes show up microscopically as increased mitotic figures, crowded nuclei, and loss of normal tissue architecture. Tumor suppressor genes do the opposite. They restrain growth and enforce checkpoints. Think DNA damage, stop the cycle. Too much stress, trigger apoptosis. The key difference is both alleles must be mutated. It's the two-hit concept. These mutations are often associated with familial cancers. The most famous example would be P53, the cell's quality control supervisor. If oncogenes are a stuck accelerator, tumor suppressor loss is cutting the brake lines and removing the emergency brake. Now, this table is not about memorization, it's about recognizing patterns. Most oncogenes fall into a few functional categories. Signal transduction, growth factors or receptors, cell cycle regulation, or transcription control. So let's walk through a few. KRAS, or KRAS, is a signal transduction protein. It's commonly mutated in colon cancer. When KRAS is on, it sends nonstop signals downstream. Then we have BRAF, BRAF, another signaling protein, strongly associated with melanoma, often produces aggressive cellular proliferation patterns. Cyclin D, it regulates progression through the cell cycle. So overexpression, we have cells skipping checkpoints like they're optional. When these pathways are overactive, what you see on slides is this: high nuclear to cytoplasmic ratios, increased mitosis, and loss of orderly tissue layering. Worthless but sticky facts. KRAS mutations are so common that they're basically the frequent flyer miles of colon cancer genetics. Now let's flip back to the brakes. Tumor suppression genes don't promote growth. They prevent inappropriate growth. So examples, APC. This inhibits signal transduction. It's central to colon cancer. And loss leads to uncontrolled beta-catenin signaling and polyp formation. So RB, which is retinoblastoma gene, this regulates the G1 to S checkpoint. When RB fails, cells move into DNA replication without permission. Then here's one that everybody seems to recognize, the BRCA1. It's involved in DNA repair. Loss doesn't directly increase division. It increases genomic instability. And loss of tumor suppressor genes doesn't make cells faster immediately. It just makes them sloppier. So sloppy DNA, we will have abnormal nuclei, pleomorphism, and so that means chaos on our H&Es. As an analogy here, tumor suppressors are the proofreading software. When they fail, typos pile up until the document becomes unreadable. This diagram looks intimidating, but it's really just a summary of everything we've already talked about. Each hallmark represents a survival advantage gained by tumor cells. Some highlights: we have sustaining proliferative signaling, which is oncogenes. Evading growth suppressors, that's our tumor suppressor loss. Resisting cell death is defective apoptosis. Inducing angiogenesis, this is where the tumors recruit the blood supply. Activating invasion and metastasis, this is tissue destruction and spread. These hallmarks translate into irregular borders, stromal invasion, neovascularization, and tumor-associated inflammation. Cancer doesn't invent new behaviors, it exploits existing cellular survival tools and just turns them up to 11. Slide ties everything together. Cancer does not happen overnight. It's a stepwise accumulation of genetic changes. We have familial retinoblastoma. Its first hit, it was an inherited defective RB1 allele. The second hit is the mutation in the remaining normal allele. The result? We have early onset cancer with very few total mutations needed. Adenocarcinoma sequence. We see this in colon and pancreatic cancers. It begins with a benign lesion, progresses through multiple genetic alterations, and then ends as invasive carcinoma. The key gene here is APC. It's often the first mutation in colon cancer. Familial loss is FAP, or familial adenomatous polyposis. This explains why we see dysplasia before carcinoma, gradual architectural distortion, increasing cellular atypia over time. Cancer progression is less like flipping a switch and more like stacking bad decisions. Each one makes the next a little bit easier. Slide is one of those quietly very important ones because this is how cancer actually happens in real tissues, especially in the colon. What we're looking at here is the adenoma carcinoma sequence, which is a stepwise accumulation of genetic damage, not a sudden event. Normal colonic epithelium doesn't just wake up malignant one morning. The first hit is usually loss of the APC tumor suppressor gene, which disrupts regulation of the beta-catenin and cell adhesion. Histologically, this is when we start seeing mucosa at risk. Architecture may still look mostly normal, but control mechanisms are already slipping. As additional mutations accumulate, especially KRAS activation, we get adenoma formation. These are benign, but they are genetically abnormal and clonal. The cells are already breaking the rules. Eventually, loss of TP53 and other tumor suppressors removes the final checkpoints. That's when we cross into carcinoma with invasion, chromosomal instability, and frankly, ugly histology. Think of this like a car losing systems one at a time. First, the check engine light comes on, which is the APC. Then the brakes start acting weird, which is KRAS. Eventually, the airbags are disabled, which is P53. The crash isn't sudden, it's inevitable. Every step corresponds to increasing dysplasia, architectural distortion, and loss of differentiation, things you absolutely see on slides. So now let's talk about how those genetic changes actually happen. There are four major categories that cause carcinogenic mutations, and the key idea here is initiation versus promotion. Chemical carcinogens, these often require metabolic activation, meaning they aren't dangerous until the body tries to detox them, especially in the liver. They form DNA adducts, which, if not repaired before cell division, become permanent mutations. Tobacco smoke alone contains over 70 known carcinogens, which explains why it's an overachiever when it comes to cancer types. Radiation. Radiation causes direct DNA damage, including double-strand breaks. UV light creates thymine dimers. Ionizing radiation breaks chromosomes. Cells that survive but repair incorrectly become ticking time bombs. Infectious agents. Viruses can insert genetic material or interfere with tumor suppressor proteins, while bacteria like H. pylori cause chronic inflammation that increases cell turnover and mutation risks. And then we have familial predisposition. Here you inherit the first hit, meaning every cell starts closer to malignancy than average. Some worthless but useful knowledge here. Your liver activates many carcinogens using the same enzymes that metabolize drugs. Detoxification is sometimes a little too enthusiastic. Slide is cancer development in slow motion. Carcinogenesis is a multi-step process, not a single mutation. Initiation is a permanent DNA mutation occurs. The cell still looks normal, and this is key. You cannot see initiation histologically. Promotion. The initiated cell is stimulated to divide. This is where pre-neoplastic lesions appear. Dysplasia becomes visible, and architecture starts misbehaving. And then we have conversion. This is genetically instability accelerates. Mutations pile up. The lesion crosses into malignancy. And finally, we have progression. The tumor becomes more aggressive, invasive, and capable of metastasis. As you move right on this diagram, you will see increasing nuclear atypia, loss of polarity, increased mitotic figures, and invasion beyond the basement membrane. Initiation loads the gun, promotion pulls the trigger, and then progression empties the magazine. This table is high yield, but I want you to understand why these pairings exist. Chemical carcinogens typically work through chronic exposure, metabolic activation, and repeated tissue injury. So take tobacco smoke. It is a precursor to lung cancer and many others. So you have repeated epithelial injury and mutation overload. Aflatoxin, you see liver cancer. So it's a mold toxin that causes specific P53 mutations. Asbestos leads to mesothelioma. So we have physical fibers cause chronic inflammation, not direct DNA mutation. Benzene has been seen to cause leukemia, so it targets the bone marrow stem cells. Many of these cancers show field effects, meaning large areas of tissue are genetically abnormal, not just the tumor you're sampling. A fun historical fact, scrotal cancer was the first occupational cancer described, and chimney sweeps exposed to coal tar in the 1700s. So PPE matters, folks. Cancer isn't always chemical or random. Sometimes it's biological sabotage. Take human papillomavirus or HPV. So high-risk strands produce proteins that disable P53 and RB, removing cell cycle control. This is why HPV-associated cancers show high mitotic activity. The Epstein-Barr virus, this drives uncontrolled B cell proliferation. It's often linked to MYC translocations. Helicobacter pylori, chronic inflammation of gastric mucosa increases cell turnover and mutation risk. This eventually leads to lymphoma or carcinoma. Hepatitis B and C, these cause chronic hepatocyte injury, and then we go through regeneration, and then fibrosis, and then ultimately carcinoma. As a histology connection, these cancers often arise in tissues showing long-standing inflammation, metaplasia, or dysplasia before malignancy develops. Roughly 15 to 20% of cancers worldwide are linked to infectious agents, meaning some cancers are technically preventable with vaccines and antibiotics. To this point, we've talked a lot about acquired mutations, things that happen over time due to environmental exposures, random replication errors, or sheer biological bad luck. This slide is about the exception, familial cancer syndromes, where someone is born with the first genetic mistake already loaded. Think of this as starting a video game with one life already gone. Let's walk through a few high-yield examples, not to memorize every syndrome, but to just recognize some patterns. So we have RB, which is retinoblastoma. RB regulates the cell cycle. It's basically a gatekeeper at the G1S checkpoint. If both alleles are lost early, especially in childhood, you get retinoblastoma. So kids with bilateral tumors is often an inherited mutation, okay? We have P53, which is the Li-Fraumeni syndrome. P53 is the cell's quality control manager. So stop, fix it, or self-destruct. When P53 is defective, cells with DNA damage just keep going. That's why Li-Fraumeni patients develop many different cancers, often at young ages. APC, which is familial adenomatous polyposis. APC keeps B. catenin in check. Lose it in hundreds to thousands of colon polyps. Cancer is essentially inevitable without intervention. From a histology standpoint, this explains why adenomas matter. So BRCA1, we have DNA repair, specifically double-strand breaks. When repair is impaired, mutations accumulate faster, not because cells grow faster, but because they fix damage poorly. We have mismatch repair genes, also known as Lynch syndrome. These errors are subtle, so single base mismatches, but they add up. That's why Lynch is associated with cancers in multiple organs, especially colon and endometrium. So a big takeaway here is familial syndromes don't guarantee cancer. They lower the threshold for transformation. Now we move from genes to what we actually see under the microscope. Cellular atypia is a spectrum, not a diagnosis, not cancer, but cells starting to look suspicious. Classic features you should be comfortable recognizing are enlarged nuclei, increased nuclear to cytoplasmic ratio, irregular nuclear contours, prominent or multiple nucleoli, and increased or abnormal mitotic figures. In histology terms, this is when the cells start breaking the unspoken rules of polite epithelial behavior. An important clarification, atypia does not automatically mean malignancy. It means the cells are changing faster than they should, and the architecture is starting to slip. A histotech lens here, fixation, section thickness, and staining quality can exaggerate or obscure atypia, so the context matters. Dysplasia is atypia with a resume. These cells aren't just weird. They've acquired some of the genetic alterations needed for malignancy, but they're still contained. Some key concepts. Dysplasia is localized to the tissue of origin. It ranges from low grade to high grade. High grade dysplasia is often synonymous with carcinoma in situ. And dysplastic lesions are precursors, not guarantees. So examples you'll see over and over: tubular adenomas of the colon and cervical dysplasia. Why this matters clinically and histologically is that dysplasia has not crossed the basement membrane. Surgical excision is often curative, and that makes early detection incredibly powerful. This is cancer still stuck at the starting line. This is the moment everything changes. The single most important distinction between in situ disease and invasive carcinoma is this: has the basement membrane been breached? Invasion is local, continuous spread into adjacent tissue. Once invasion occurs, the lesion is no longer contained. The architecture becomes destructive, not just disorganized. From a histology standpoint, invasion often looks like irregular nests or glands, desmoplastic stromal response, or loss of normal tissue boundaries. Why size matters. The larger and deeper the invasion, the harder it is to surgically cure. So early invasion, we will have better margins, better outcomes. Think of the basement membrane as the fence. Dysplasia leans on it, invasion jumps it. Metastasis is not invasion on steroids. It's a completely different skill set. Metastasis means non-contiguous spread, movement through lymphatics, blood vessels, or body cavities, establishment of a new tumor in a distant site, colon cancer to the liver or brain, breast cancer to the lung, any carcinoma to the lymph nodes. The metastatic process requires cells to detach from the primary tumor, degrade the extracellular matrix, enter circulation, survive immune attacks, exit the vessels, establish blood supply, and then grow in a foreign environment. Most tumor cells fail this journey. The ones that succeed are the worst behaved cells in the room. Metastatic tumors often resemble the primary. That's why morphology and immunohistochemistry are so powerful. So when we talk about the natural history of cancer, we're really talking about a story. Genetic damage leads to atypia, which leads to dysplasia, which can lead to invasion, and ultimately metastasis. Every step leaves a footprint, and our job in histology is learning how to recognize those footprints early. Now that we've talked about how cancers form and progress at the cellular level, we need to talk about where the cancer is and how far it's gone. And that's what stage tells us. Stage is not a microscopic concept, it's a geographic one. When we talk about stage, we're answering the question, how much territory has this tumor claimed? That's why staging is built around the TNM system. T for tumor, how big it is and how deeply it has invaded. N for lymph nodes, whether it's reached regional lymph nodes, and M for metastasis, whether it's traveled to distant sites. From a histology standpoint, this is where depth of invasion matters. Breaking through the basement membrane is just not a diagnostic milestone. It changes staging, prognosis, and treatment. This is also why in situ lesions behave very differently from invasive carcinomas. As long as malignant cells stay above the basement membrane, they're essentially trapped. Once they cross it, the doors to lymphatics and blood vessels are wide open. A histology pearl here would be the stage is determined by what the tumor has done in the body, not how ugly it looks under the microscope. Stage is geography, grade is personality, and grade lives entirely under the microscope. Grade tells us how much the tumor still resembles the tissue it came from. A well-differentiated tumor is trying, maybe not succeeding, but trying to behave like normal. Glands still form glands, squamous cells still attempt keratinization. A poorly differentiated tumor, on the other hand, has completely abandoned the blueprint. Histologically, poorly differentiated tumors show marked variation in cell and nuclear size, high nuclear to cytoplasmic ratios, and prominent or multiple nucleoli. We'd see frequent mitotic figures, sometimes abnormal ones. But here's the important conceptual takeaway. Grade predicts behavior, stage predicts outcome. You can have a small early stage tumor that looks absolutely wild under the microscope, and a large advanced tumor that still looks deceptively organized. That's why pathology reports always include both grade and stage. They answer two very different questions. Worthless but sticky knowledge. The word anaplasia literally means to form backward. It's not just ugly cells, it's cells that have forgotten their identity. Before surgery ever happens, clinicians use imaging to estimate stage, so ultrasound, CT, PET scans. But here's the key point for this course. Imaging suggests stage, pathology defines it. Radiology can estimate tumor size and look for suspicious lymph nodes, but it can't tell whether a structure is truly invaded, whether margins are clear, whether lymph nodes actually contain metastatic cells. That's where we come in. The definitive TNM stage is assigned by the pathologist after surgical removal of the tumor based on gross examination, microscopic evaluation, and lymph node assessment. This is why proper tissue handling, orientation, sectioning, and submission are not just busy work. They directly impact staging accuracy. Missed lymph nodes equal underestimated stage. Poor sectioning means missed invasion. Bad fixation can lead to compromised diagnosis. Slide ties clinical symptoms directly back to what cancer does to tissue, and every bullet here has a histologic explanation. A mass forms because malignant cells proliferate without restraint. You're seeing clonal expansion made visible. Pain occurs when tumors destroy tissue, compress nerves, or trigger inflammation. On slides, this often correlates with necrosis and stromal reaction. Obstruction happens when tumors narrow or block hollow organs, think colon or the bronchus. And histologically, you'll see luminal compromise and thickened walls. Hemorrhage is common when tumors ulcerate mucosal surfaces. On slides, this often corresponds to surface necrosis and friable tumor tissue. Pathologic fractures occur when tumors replace or weaken bone. Histologically, normal bone architecture is replaced by malignant cells. Symptoms are not abstract. They are direct consequences of tissue destruction that you can see under the microscope. Screening exists to catch disease before it becomes clinically obvious, but not every cancer is a good screening candidate. Effective screening tests must detect a disease when it's present, be safe, affordable, and easy to administer, and improve survival when applied to a population. From a pathology standpoint, screening doesn't diagnose cancer, it selects who gets tissue. A positive screen leads to a biopsy, and only histology can confirm whether disease is present, whether it's invasive, and what type of tumor it is. This is also where overdiagnosis becomes a real issue. Some lesions look alarming microscopically, but may never progress clinically, which is why interpretation matters just as much as detection. And a final thought here, screening opens the door, histology decides what's actually inside the room. Okay? Okay, up to this point, we spent a lot of time talking about what cancer does and how it behaves. Now we need to talk about why it happens in the first place. And that brings us to risk factors. Broadly speaking, cancer risk falls into three buckets: environmental agents, genetic changes, and behaviors. And yes, these overlap more than you'd think. Cancer is nothing if not an overachiever. From a histology standpoint, risk factors matter because they influence what kind of damage we expect to see at the cellular level. Different exposures create different patterns of injury, mutations, and architectural chaos. Think of risk factors like repeated insults to tissue. One paper cut won't hurt you long term, but thousands of tiny paper cuts over years, that's when pathology starts paying attention. And remember, risk does not mean destiny. It means probability, not a guarantee. Our job in the lab is to recognize the downstream effects when probability becomes pathology. Chronic exposure leads to chronic inflammation, which leads to increased mitotic activity. Increased mitosis equals more opportunities for DNA replication errors. This is where normal-looking tissue quietly starts its villain origin story. This slide is important because it highlights something we don't always get in pathology, and that is control. These are risk factors that, at least theoretically, people can change. Cigarette smoking. Smoking is the gold standard of please don't do this to your epithelium. From a histology perspective, smoking causes chronic irritation, metaplasia, dysplasia, and eventually carcinoma. In the lung, we often see squamous metaplasia replacing normal pseudostratified ciliated columnar epithelium. Basically, the tissue waving a white flag and saying, fine, I'll adapt. Some worthless but useful knowledge. Squamous cells are tougher, but they lose cilia, which means mucus clearance suffers. That stagnant mucus becomes a carcinogen's best friend. High-risk sexual behaviors. These are primarily linked to viral-associated cancers, especially HPV. Histologically, HPV-associated lesions show choriocytosis, nuclear atypia, and disordered maturation. Changes you'll absolutely be expected to recognize later. This is a great reminder that not all carcinogenesis is chemical. Some of it is biological sabotage. Alcohol consumption. Alcohol is especially dangerous when combined with smoking. They are the worst kind of lab partners. Alcohol increases mucosal permeability, making tissues more vulnerable to other carcinogens. Translation: Alcohol holds the door open while tobacco wrecks the house. Chemical exposures, we have occupational and environmental exposures that often produce organ-specific cancers, depending on how the chemical is metabolized. From a histology perspective, these cancers often show long latency periods, meaning the cellular damage happened decades before the slide ever landed on a microscope stage. Obesity and dietary factors. Adipose tissue is metabolically active. It produces estrogen and inflammatory mediators. That's why obesity is linked to breast, colon, and endometrial cancers, all of which show hormone-driven proliferative changes long before malignancy is diagnosed. As a histology pearl, chronic low-grade inflammation doesn't look dramatic, but it quietly sets the stage for neoplasia. Slide may look simple, but it's one of the most clinically important ones in this entire lecture. Most patients with cancer do not die because a tumor exists. They die because of the systemic consequences of that tumor. So infection is the most common. Tumors disrupt barriers, treatments suppress immunity, and suddenly opportunistic infections take center stage. In pathology, this often shows up as secondary inflammation, necrosis, and sepsis-related organ damage, sometimes far removed from the original tumor site. Cachexia is not just weight loss. It's a metabolic hijacking where tumors alter cytokine signaling and energy utilization. Histologically, you'll see muscle wasting, fat depletion, and organ atrophy. The body is essentially being out-metabolized by the tumor. Worthless knowledge here, cachexia cannot be reversed simply by feeding the patient more calories. The metabolic signaling is fundamentally altered. The metabolic and endocrine effects. Hormone-secreting tumors can cause life-threatening imbalances. Think paraneoplastic syndromes. Sometimes the hormone effects kill the patient long before the tumor burden does. And then hemorrhage. Tumors are fragile, poorly vascularized, and prone to bleeding. Massive hemorrhage is especially common in tumors eroding into major vessels or mucosal surfaces. Slide exists for a reason, and it's not just to look friendly. If neoplasia feels overwhelming, that's normal. Cancer is complex because it operates at every level: molecular, cellular, tissue, organ, and systemic. As histotechnologists and future pathologists, your power is in recognition. You won't always know why a cancer developed, but you will know what it looks like, how aggressive it is, and what story the tissue is telling. And that story starts long before the patient ever knew something was wrong. So yes, ask questions. That's how good histology happens.